Hi there, guys. All right, guys. Hey there. For those of you who don't know me, I'm Paul Hein. I'm here for procedure day. We'll be talking about needle cricothyroidotomy. So the overview is we're first going to talk about the anatomy. We're going to talk about the indications, how to get set up, how to actually place a catheter, how to adapt the angiocatheter to your bag, which we'll talk about in detail. Talk about ventilating and difficulties with that, your exit strategy, and potential complications. Also, anyone feel free to weigh in at any point. It's a complicated, difficult procedure, and we don't do anything enough. So, opinions, experiences are valuable for sure. So let's start with the anatomy. For those of you who have never done this on yourself, I highly recommend starting at your mental process at the chin and feeling down until you find your thyroid cartilage, is that big, beefy cartilage. Biggest one in your neck. If you go slightly below that, you'll actually find your cricothyroid membrane, which doesn't feel like much. It feels really more like a gap between your thyroid cartilage and your cricoid cartilage. Your cricoid is where you're putting pressure, pressure and intubation. It's a solid ring. It's the biggest of your tracheal rings. If you go a little further down for your cricoid cartilage, you'll feel your tracheal rings. On either side of the cricothyroid membrane, you have cricothyroid muscles, which you're mostly just trying to avoid. You're really aiming for the midline. And in an adult, this is much easier to do. Adults have larger space between their cricoid membrane and the thyroid membrane. This is why we can actually cut open in here and largely avoid damaging any major structures. Probably the worst when it hits the thyroid. There's a cricoid cartilage, but there are many, many things that we want to avoid. But there's enough space, if you look on the model here, there's enough space to actually fit the catheter, this is actually a cannula, fit the cannula into the airway. This is a proper cricothyroidotomy. It's not a needle cric, which is what we're actually going to talk about further detail today. By comparison, pediatric airways have a lot of major differences. Starting from the top, they have larger heads, so they're harder to position. They have larger tongues, they have a floppy epiglottis. The airway itself is smaller in diameter. It actually gets more narrow below the vocal cords, unlike adults where the vocal cords are narrow at this point. The trachea itself is shorter in length and is more interior, and the cricoid cartilage and the thyroid cartilage actually overlap by quite a bit, so the membrane is a lot smaller. This is why we like to use a needle cric, is because your potential for damage is much, much lower. There are problems that come up with that, which we'll address. This can be very hard to assess because, one, the space is very small compared to an adult. Two, it's small in general because you might be doing this on a neonate, and there might be complicating factors such as overlying trauma, burns, edema, etc. So if you have asymptomatic pediatric patients, you feel comfortable with them, they're happy, and you can, grab them by the legs and swing them around, then maybe you should see if you can sneak in a feel on their cricothyroid cartilage and figure out your membrane. If you're having a bad airway day, this applies to adults as well as kids, you can consider taking out a pen and marking the spot beforehand. It is much nicer to have marked out before you actually have to go fishing. And that's because of this study. This study actually keeps me up at night because they took pediatric anesthesia attendings or residents with more than 4 years of experience they've done in Europe, and they had less than 100 patients, but they separated it up by age group. They had these folks try to feel for the cricothyroid cartilage and identify the location. They were correct less than 30% of the time for everyone from years 0 to 8. As you get up in size and become more like adults, you get to a hefty 38.2% correct on their first attempt at actually feeling it. The extent how far to find cric column on the right is saying if you were to extend a midline incision, starting with the point and moving outwards, how far would you have to cut to find the thyroid, the cricothyroid membrane? Because if you can't find what you're going for, in adults you make a midline incision. You could theoretically do this in kids too to find the right target. It tends to not happen, but that's how far you'd have to go to cut. So that means they're off by, on average, at least 10 millimeters. The takeaway from this is please learn your pediatric airway anatomy. It's different than adults. And also this study excluded kids with a Mallampati greater than or equal to 3, any prior tracheal instrumentation damage, complications, stenosis, or any emergent case. And that sounds like most of the kids that we're going to be doing this on anyway. Overall, one other takeaway, they tended to shoot lower than they should have. you don't want to go to the thyroid cartilage, but maybe we are underestimating the location. We should be aiming higher. Indications for a needle cric are very similar to those in an adult. The big number here is that by your 12th birthday, you're no longer getting these. That doesn't vary by who you ask, and also it varies if you're decides like an adult, you're probably fine. If spinal muscular atrophy, maybe not. And then other than that, it's basically inability to ventilate, inability to oxygenate, and inability to intubate. Bad cases of this might include trauma, burns, and injections. Kids are likely to drink whatever they find. They can get really, really bad caustic injuries, or burns from drinking boiling water. Anaphylaxis, obviously. Airspace infections, your kids, especially your non-vaccinated kiddos, they are at higher risk for a number of nasty things like epiglottitis if they weren't vaccinated against H. flu type B, tracheitis, croup, peritonsillar abscess, retropharyngeal abscesses. All these can make you unable to intubate. 2% of pediatric intubations are quote unquote failed and will result in some kind of surgical airway. That's intubation. But other than that, you can pretty much just apply to it. Contraindications, I think most importantly, all airway procedure contraindications are relative in the end, as long as you know they'll work. And that's why the only absolute contraindication is if it won't work. If you transect your trachea at the level of your collarbone, you put in a cric, it's going to do nothing for the patient. What you need to do is probably stuff an ET tube in there. And that's a whole other talk. Relative is that if your cric is going to be hard, you're just going to have to think about it possibly or think about other options. Pretracheal angioedema means you just have a lot of soft tissue to cut through. You might not be able to clear landmarks at all. Known pre-existing tracheal derangement, these are people who have prior prolonged intubations, people with certain kinds of connective tissue diseases, or bleeding disorders, which is not just a little bit of blood trickling in your airway or a little bit of blood in your field. We're really worried about creating a human. But you have to do what you have to do. So as far as the setup for the bare minimum things you want to have, you want to have an angiocatheter and a needle. I just want to clarify at this point, just for the interns, the angiocatheter is the actual plastic that sits on top of the needle. They together are your angiocatheter needle complexes. The thing is you can take an angiocatheter off of another needle and put it onto a needle that will work better for your setup. We'll talk more about that. You're going to want a flush syringe, or really just any syringe with a little bit of water in it. I like to use a flush, so that way if there's syringes full of clear liquids, we know what they are. If it's in a flush syringe, it's probably just it. You're just using this to confirm by withdrawing with bubbles, and we'll see that. You're going to have some kind of adapter going from your angiocatheter that is going to be placed in the patient's neck to a bag. I'm also going to go over this in just a minute, but there's a couple of different ways to do it. This is probably one of the most complicated parts of this in that it's just something that a lot of people don't know, and it's really easy to forget. There's more than one way to do it. You're going to want your bag. Obviously, pediatric sized bags are usually appropriate, but if you have an adult bag, you make it work. And then sterile draping, sterile prepping, PPE. This is an airway procedure, eye protection, and every other protection, especially in this day and age. Additional setup. This is a bunch of bonus stuff. An 11 blade is very nice in pretty much any airway situation ever. This can be useful for passing a large angiocath in the way that you nick the site of the central line insertion near the guide wire. It's a very similar concept. Jet ventilator is very nice to have access to. I'll show you how to make one later. It's kind of a ratchet together jet ventilator, but there are commercially available ones. You can see this big beefy oxygen hookup right over here. This hooks in much in the way that a high flow nasal cannula would. Here's a pressure gauge and an on-off valve, so you can tell how much pressure you're giving, because barotrauma is actually a huge problem when you're doing a needle cric. There's a filter to avoid any chunks going in or out, and then this right here hooks into your this. I've never seen this at Kings County or downstate. I'm unaware of it being Kings County or downstate. Everyone I asked can teach you about it. So trust in your BVM. Learn how to put these together anyway using parts off the shelf. This is your everything else, your monitor, your suction, your medications, your sedation and paralysis, your supportive care, your IVs, your pressors that are already mixed up for when you get a little peri-intubation. And finally, please, please, please call for help. This isn't the time to be brave. This is a time to call every single person you know. Anesthesia, trauma, ENT, depending on the case, maybe OMFS would get involved. I don't care if it's just an ENT intern. It's certainly better than just me alone. These people need definitive management, and that is not going to be you. They're going to need some kind of management, and the usual rate is about 45. This is an angiocath and needle. So here's a silly thing about the Kings County angiocath situation. I've heard that there's a slightly different situation at downstate, but I've never seen it. All right, everyone can look on there. You know what? Actually,
yeah.
So we are trying to put a great deal of air through in angiocath, and this is a county. It's usually a 14 gauge, the biggest thing that we can find commonly. That you find on a little mechanism like this. This is the needle. That's a safety mechanism. Usually, you put it in, you get flashing.
Paul, can you show everyone else here too?
So the problem with this is that this mechanism with the needle and the safety and everything else, you can't hook a syringe into the back of this. There's no way to confirm replacement because you need to confirm replacement by getting into the tracheal lumen and then seeing bubbles of air so that you don't blindly dissect into various very delicate tissues. So the way you can get around this is in the central line kits, there's an 18 gauge needle that has a catheter on it, but you can take that catheter off, or you can just use a regular 18 gauge needle and thread this catheter on top of that. Or alternately, there are spinal needles which are 18 gauge. These have an internal stylet. You're going to want to ditch that. You now have an 18 gauge needle, and you're going to put the 14 gauge over that. And there you go.
Can you show us two here?
So the one thing you have to note here is that when you're placing this needle in the airway, because the needle is slightly smaller than the catheter, that means that you're more likely to have to use an 11 blade to make it connect. But that's going to allow you to actually pass a catheter. But the difference between an 18 gauge and a 14 gauge is pretty meaningful because this is pretty comparable to giving blood in a massive transfusion protocol. Every bit of gauge you can get. All right. Great. So placing the catheter is actually relatively easy, even though things are better at county. Shout out to our admin. All the interns should have some experience placing their own IVs by now. This is basically placing an IV. You place your needle in through the cricothyroid membrane, ideally, if you're not going too low, as most anesthesiologists do. You aim at a 45-degree angle. You insert into the cricothyroid membrane, and you start withdrawing as soon as your needle goes under the skin. As soon as you hit bubbles, you advance using a Seltzer technique, meaning you just thread the catheter over the needle, making a nick if you have to, and advance it all the way and hug. And now that you've done this, you should now have someone holding the catheter at all times, because one of the most common complications of this is that you kink this catheter. If you kink the catheter, you can just lose your airway because it's that delicate. Commercially available catheters, sometimes they're made out of Teflon. Otherwise it's very robust. I've even heard of people using the dilators from Fortis as their cric, which requires a lot of cutting. So that's getting into dodgy territory, but at least it won't kink on you, which is a nightmare situation. So someone should be anchored on that. As far as adapting your angio catheter to the bag, there's a couple of different ways to do it. And this is complicated because how do you adapt an IV line to an airway situation? And there's 3 different ways I'm going to show you. I have some of these at my desk right now if anyone sees me at any point today or at any point in the audio. First one's the easiest. You can see it on the screen, but I'm also holding it up to the camera. This is a 14 gauge catheter, which is in the patient's neck. And this is an adapter for a 3 millimeter endotracheal tube. You'll find this in the crash cart. This is for a neonate. It's in a different part of the supermarket. I had to run around for a bit. But this is the simplest way to connect. Problem is that this isn't very flexible, so you're more likely to have to be careful with the bag right next to the patient's neck and making sure that you're not pulling something out. Just less parts is better, and especially if you're not moving around and you're just trying to get something, is as fast as possible assembly, and less parts can be better because it's maybe less likely to fall apart. You can also take a 3cc syringe, hook it up to your angio, which I'm holding up right here, and in the back of it, I've stuck a 7mm endotracheal tube adapter, and then this just hooks into your angio catheter, and you're done. And you can do the bag from the back like this. Finally, probably the most length-intensive option, you take either a 6cc syringe with a couple of smaller endotracheal tubes or a 10cc syringe in any endotracheal tube. You can just jam the ET tube in there, inflate the balloon like you intubated someone, and there you go. Now you have this big flexible arrangement. You'll just want to be careful with this, as you'll want to be careful with any of these. And you can even cut down the ET tube, as you can see in this image. But that's getting a little arts and crafty. And this is pretty fast to make. It doesn't require a lot of aim. It's probably the fastest one to make with materials where you don't have to struggle to find them, because 10cc syringes are everywhere, and you can just pop the back of a flush and use one of those. And the adult-size ET tubes are usually easier for us to find than the ped-size ones. For us specifically, your mileage may vary based on where you're located. This is probably the part that whenever this comes up, everyone always, probably 70% of the people I talk to about this, you still have to sit there and review and say, oh, is it the 3 or the 7 or the 10? Just remember 3s and 7s. So you either need a 3 adapter or 3 syringe and a 7 adapter. And once you're using a 10cc syringe, it doesn't matter. You're just jamming whatever you've got. And being able to put this together is something it's worth doing at least a couple of times yourself. Even for me, it was a little unfamiliar because I'm jamming parts together for the first time. And I'm glad that I did it for this and not in the setting of peach recess. Ventilating gets a little bit complicated. This is your jet ventilator. It requires an aeronautics degree to be able to operate. Assume you'll need to do a BVM at least temporarily. Also, you're never going to be able to transfer this. And if you're trying to get the kid to the operating room ideally, which is probably going to be getting their definitive airway. But if you want to make your own, there's this method, which is just connecting your angio catheter to a 3-way stop cock, which you connect to air tubing. And the way you gauge the pressure is that for every year of age that the patient has, you give them 1 liter per minute, and you titrate up as necessary. Again, based on chest wall movement, but that can be based on a lot of patient-independent factors. Again, a pediatric BVM is just fine. You're going to have to use it anyways. You might as well get comfortable with it. Many people prefer BVM over jet ventilation, as there's a natural off valve, so it's less likely to cause barotrauma, which is one of the most common side effects or complications of this procedure. The problem is that the patient is now breathing out of a tiny little hole in their neck, and the question of their upper airway is how much is left to breathe. When we are talking about ventilation, the reason why we're doing this is usually because they can't breathe out through there. Obviously, you could just have a difficult intubation where the person's airway is actually somewhat intact. They've lost their ability to breathe, and their airway curves, and you can't intubate it with what you have. So if you have a lot of pressure coming into the lungs, remember that your vocal cord still can be open, so you're still gassing pressure through your mouth. So if your mouth is completely open, your airway is completely intact, you might need to inject higher pressures if their airway is closed, which is why barotrauma is such a problem, is that it's hard to tell where you are in these delicate lumps. If they're exhaling through just a tiny little angio catheter in their neck, you may need to help them exhale. You may need to actually push on their rib cage. And related to this, their ITE ratio is going to be a lot higher than what you usually expect it to be. In these cases, it's often around 1:8 to 1:10. You're of course eyeballing it because all of these measures are manual. There's no ventilator. There's no respiratory coming to save you. It's going to be your hands on this case, and you'll probably want to risk it for someone else. Also, because of this bad ventilation, no matter how hard you try, you can well expect that these kids are going to get a little acidotic. So if they have massive asthma, and they're likely to tank. Just try to see that coming. And If you, of course, build up too much pressure, it's much like breath stacking in asthma. Too much pressure will decrease your return to the left side of your heart, so you can drop your blood pressures, and you can easily just suddenly take your pressure by causing a pneumothorax. It's much of the same. It's just for all of these forces, just remember that they can be changing for any single patient. Your airway can be completely open or can be not open. It's probably going to be on the side of more open and less, but many people can still get some air out even if they can't get air in. Like how people have stridor when they breathe in, but they don't have stridor or upper airway obstruction. Finally, for your exit strategy, just please don't lose your airway. Just stabilize it, and everyone else's job is way less important than yours. An easy way to just start is you can just place a large tegaderm on top of this. If you think you're going to be there for that long and you just want to suture it in place, I don't think anyone would do it. As far as underlying causes, like think about your case, think about what's going on with them medically. Do they need? Do they have any other? Is there anything else that you can do for this patient that will help them? Just don't forget to fly the rest of the plane, because this kid, if they have massive burns or sepsis or something else, they're going to have a lot of issues. Think about antibiotics. Consider steroids. See if you think it'll help your airway. And think about that for like now that you've bought yourself some time. Obviously, I keep talking about surgical airway anesthesia, ENT. Just remember that you might also be able to fix the issue yourself, whether with EL, BL. This might be a time to pull out the central line kit, steal the guide wire, and do a retrograde wire-guided intubation, where you basically put the guide wire in the opposite direction and catch it coming out the mouth of the McGill, thread an ET tube on that, and get it down past the course. Or maybe you need fiber optic. This is complicated, and don't assume that you're going to be able to do it. And keep ventilating. Keep an eye on sedation and paralysis as well. That's going to help with your ventilation. Oxygenation is not going to lose out as much to ventilation here. It's obviously still going to be a problem. Your oxygen will be cranked to 100%, in whatever form it's going to be. So as complications, the two most common are kinking and barotronic. Kinking of your angiocatheter can make you just lose it. It's just like kinking an angiocatheter and someone getting an IV. If they're getting an infusion of something, if the angiocatheter is kinking, or if it's just sliding out a little bit and you don't feel comfortable advancing it in, you can always reconfirm the position by withdrawing with a little bubble syringe, and you can always advance it further by taking a guide wire. Again, no one's going to blame you for doing a central line kit. Thread the guide wire over the angiocatheter. Guide wires use your 18 gauge, and then re-advance or just change out the catheter completely. Again, whether you want to bother to do this in a kit or whether you just want to take what you have, up to you. Other things to look out for are bleeding. It's nice to have suction as it is for any airway condition, but just remember that if they have a hematoma, there's not much you can do about it. Tracheal perforation, it doesn't include, the esophagus is straight behind the trachea, but you can get into the mediastinum, you can actually get spine, which can actually cause infection. Skin is obvious, especially during prep, because everyone's freaking out, or if it's been contaminated from bad trauma or something else. You can get any one of these spaces can become infected. There are cases of vertebral osteomyelitis happening from this, as well as mediastinitis, which is an emergency, and that's part of the things that develop later. And we don't think about it as much. But that and tracheal stenosis and going along with that damage to all our other airway structures is part of the things that we don't think about, but is why we're needle pricing in the first place. And you think, why don't we cut? The answer is you'll curse a kid for life, and if they have damage to their fractured cartilage or things, these are not things that heal well. But these are complications even if you do it right. Any irritation in the trachea can do it. Just two things I didn't talk about. I've heard many people, like when this comes up, talk about placing the angiocatheter blindly, because this entire setup with pulling the angiocatheter off and putting it on an 18 gauge needle is a little hairy, and a lot of people would rather just place it and then draw bubbles afterwards. I don't know how excited I am to place something blindly in the neck, maybe in the arm, fine, but that's just something that other people would do. If you didn't have the supplies and all you had is a 14 gauge and the bubble flush, then you I wouldn't recommend it. I think the real treatment here is having everything prepared, having all of the things that I showed you prepared in a bag in every PGD that we work in with a big sign on it saying this is the needle Craig kit. Try to do things as appropriately as you can. And then the other thing I didn't talk about was using an ultrasound to identify the cricothyroid membrane. Initially, I didn't take this as seriously because I thought, well, it's an emergency and everyone would be running around like a nut. But when you look at that study of the pediatric anesthesia attendings having that hard of a time finding the cricothyroid first palpation, if you have a kid with angioedema or bad burns, it would be if there's any way, shape, or form in which it's favorable, you have the right size of the probe, because if you have an adult linear probe, that could just be the size of the entire neck. Or if you just have a break in between anesthesia and maybe you're getting some backing, if you can find it and definitively identify it, it would be very, very nice too. You could avoid yourself a lot of really bad complications. It's not just causing a little damage to cartilage, you could avoid getting a vascular structure. If you don't know what's going on underneath where you're feeling, you don't know what's going on. Especially in kids who can have one problem or the other. So that's something, there wasn't enough literature to really study it. They just said it's feasible, and they had like a 98% identification rate on using ultrasound to identify the cricothyroid membrane. So that's an awful lot better than the 30% they were middling at for blind palpation. The biggest takeaway from this talk is knowing your gear, knowing how to put this stuff together. Everyone should practice doing it, and they should probably practice all three methods. Finding an exit strategy is something that you're probably not going to have to think about too much, because if you're not freaking out, someone else around you probably is, and you should be. And watch ventilation, as that's probably that's really your limiting factor. That's why this is limited to somewhere, numbers range from about 30 to 60 minutes. Give pressure on the chest if you have to. Give really long I to E ratios if you have to. Get end-tidal CO2 if you can. That can be hard to hook up in line when you have everyone around the airway and a lot of bits and bobs in between, but it can fit onto any ET adapter. And it'd be nice to see how much permissive hypercapnia you can get away with, or if you think they're septic. It wouldn't be the worst time in the world to push bicarb if you were that worried about it, even though bicarb only works at very low pHs. But you just do what you can and think about it. Anyone have any questions? Can you help me flip the challenge? Thank you very much to the entire procedure day team. Thank you for your feedback and for making this presentation quickly. Other than that, feel free to reach out to me with any questions.